Hey guys. So, have you ever been very frustrated by an acute abdominal series? Yeah, I thought the answer would be yes. I wanted to go over a case today that shows how ultrasound can be used to help you in your workups for patients with small bowel obstructions. But even some will posit that it may replace an acute abdominal series for a suspicion of small bowel obstruction when you don't think someone has, say, free air, where an x-ray can actually be of help. But in run-of-the-mill bowel obstructions, how ultrasound can help. I wanted to use this case to illustrate that. So this is a case of syncope. We'll go over that picture in a little bit. Some of you may know what that is showing already. So patient 64 comes in afebrile, passed out, acute pain to his abdomen, fully clothed on arrival. His EKG was okay. So right off the bat, syncope, true syncope. Ultrasound can be used in many ways to help you in your differential, especially if they're unconscious or not giving you much information. Top left corner here, your echocardiogram can look at for fluid around the heart. It can also be used to look for right ventricular strain in PE when you think that a PE may have caused the patient to pass out. It also gives you a view of the ejection fraction. Here in the top right, a fast exam can obviously show you free fluid. Here's the aorta in a long axis view in the bottom left, and a short axis view in the bottom right. So here are a few modalities where ultrasound can help you in every workup of your syncope patient. So what was the most important discovery of 1979? You may ask. Most of you, some of you, the residents here anyway, probably had not been born. I had not been born yet either. So here are some hot ticket items of that year, some fashionable items there on the left, as well as a nice Walkman on the right side. And this is actually before he got started here at Maine Med. This is what Dr. Perrin was doing with his time. She got paid a pretty penny to jump on the bike and act as a model for this Sony Walkman. He's still getting royalties for that. But actually, ultrasound was first described. So, again, we kind of briefly alluded to how an acute abdominal series can be frustrating in many of these workups. The best study that I could find on this showed that ultrasound's about 46% sensitive, 67% specific for small bowel obstruction. Here's a picture of, or here's the same patient that was just seen in that x-ray, actually with an ultrasound. So as you can see here, it's pretty notable that there are multiple loops of bowel tracking around here. So each of these fluid-filled structures are actually bowel loops. And we'll go over this in a second, but bowel loops that are greater than 3 centimeters in the small bowel are suspicious for obstructed bowel. Here are the villi along the intestine as well. The caveat is here, not all bowel obstructions are fluid-filled. If they're air-filled, you will not see them in ultrasound. Most are fluid-filled, which do augment and help ultrasound to make that diagnosis. This was a study by Jang, who's looked at ultrasound for small bowel obstructions with, in his ED, 91% sensitive, 84% specific. So let's compare some diagnostics. This graph actually shows even better specificity for using ultrasound in small bowel obstructions. I think it probably lies somewhere between this study and the Jang study. But as you can see in both of these studies, and basically every study that I found looking through, it definitely outperforms in X-ray. And it's quicker, easier, painless, and at the bedside, so can lead you in that direction. In this question, we can talk about a little bit more, but what patients are ultrasound going to be best used for bowel obstructions? Of course, new bowel obstructions, oftentimes the surgery team wants to know where the point of obstruction is, and this helps with their surgical management, and that's totally understandable, and that's where CT comes in next. I think ultrasound can be used predominantly or nicely in patients that are recurrent obstructors that have had multiple CAT scans and are often managed conservatively in the hospital. Those patients, I think you can avoid all radiation in the ED, especially if they're not toxic, if you're not suspicious of perforation. Other people you can use them for are the patients that you think have a small bowel obstruction. Even if it's newly diagnosed, you can diagnose it at the bedside, call surgery, and put in your CAT scan and have your disposition or have the surgery team at the bedside helping out, a few hours before you would otherwise. So this can expedite management of the patient as well. Lastly, likelihood ratios. This was an ultrasound where ultrasound showed to be likelihood ratio of 9.55 if it was seen to be positive, and a negative of 0.04. So those are pretty good numbers there. So back to our patient and our technique here. So there's no real rhyme or reason to the technique. As you can see here, up and down, they talk about mowing the lawn. I just want to reiterate, you definitely want to get into the flanks. They start to here, but these are high yield areas, so into the flanks on both sides. In Canada, you can call it driving the Zamboni, which is a similar technique. Mow the lawn up and down, no rhyme or reason. So again, 3-6-9 rule, 3 centimeters for small bowel, 6 centimeters is your end limit of normal for large bowel, and then 9 for the terminal ileum. The 3 is the most common one and the best one to commit to memory when doing these scans. So here's a case of a bowel obstruction. You can see the movement of the intestinal contents is back and forth. Those loops, if you want to look on the right side of the screen here, are right at that limit of normal of 3 centimeters. Here's another nice example. Notice this pendulous movement back and forth like a seesaw. That's characteristic of a bowel obstruction as well. Again, dilated loops that are fluid filled. Here's a beautiful representation on the right and the left. This is the same patient. Again, these layered bowel loops, as well as you can see here some pericolic fluid, and this happens when fluid transposes and moves across the borders of the lumen of the bowel because of the intraluminal pressure involved. And you'll see this on CAT scans of your patients as well. This is the ultrasound representation of this pericolic fluid. Again, another example, sort of chaotic movement in the lumen of the bowel. You could bring your depth down a little bit here and give yourself a better view, but dilated loops, if you want to pause it and measure it, those are at about 3 to 4 centimeters. This is a secondary sign. This is actually the stomach, so an incredibly large distended stomach from backflow of contents into the stomach. And lastly, this is actually a small caveat, but you notice there's no peristalsis here. There's no movement. The other pathology or worrisome clinical diagnosis that you might experience or you might approach is your patients with ileus, whether it's medical or surgical related, but those patients will not have peristalsis. A bowel obstruction will exhibit peristalsis, with one important exception, and this would be that peristalsis can be lacking in patients that have had an obstruction long enough to cause dead bowel. Those patients are typically more ill-appearing and toxic, and this ultrasound actually shows small air levels in, or air features and artifacts in the wall of the lumen. This is definitely more an advanced ultrasound pickup, but in patients that have pneumatosis, this is your characteristic finding. So as you remember, air does not help with ultrasound transmission, so it will be bright and white, and these little speckles of air are noticed along the lumen. You'll also see this in necrotizing fasciitis and soft tissue, these kind of bright signals. So just to clarify and go over quickly, small bowel obstructions tend to be dynamic or adynamic if it has progressed to pneumatosis. Ileus will be adynamic, so you will not have any peristalsis. Both will be greater than 3 centimeters at times, especially for small bowel obstructions. Ileus doesn't necessarily have to be, but often will be. Small bowel obstructions can be fluid or air-filled. Same with ilii or iliacis. Uh, both can exhibit some pericolic fluid, and small bowel obstructions will have that notable pendulous movement, which is very characteristic. Thickened bowel walls, plus or minus air, and that's it. So I know that brings up a lot of questions. There's a lot of images. I think the major point is for patients that you're suspicious of a bowel obstruction, put the probe on the belly. It's a really easy exam to do, and your images are pretty very not difficult to obtain, and they exhibit nice features. So it's easy exam. Try it at your shop, and you can hopefully get your surgery colleagues on board. We'll be actually rolling out a study pretty soon looking at small bowel obstructions in the ED here at Maine Med, so we will give you some more teaching on this. But this is called, or what we called in our fellowship down in Boston, is the waterfall of poop. So this is stool falling off the precipice. So hope you enjoyed. Let me know if you have any questions. As always, thanks.